This tablet, it's in,
Okay, everyone, welcome. My name is James Orbinski. I'm the director of the Dodela Institute here at York University. And it's a pleasure to welcome everyone here today to our weekly graduate seminar series. And Paul McDonald, Professor Paul McDonald is our speaker today. And Paul, can you pull up the slide, please? Paul will be addressing the question, are distinctions between communicable and non-communicable diseases still useful? And why should we care? I will give you a more comprehensive biography of Paul in a minute or two. But I would just like to begin by acknowledging that we are here today at York University on the campus in Toronto, and that York University is situated on the traditional territorial area known as Takaronto, and we acknowledge its current treaty holders, which are the Mississaugas of the Credit First Nation. And we also acknowledge, excuse me, that this is also the traditional territory of many Indigenous nations, including the Anishtabak Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and of course the Métis. And this territory is subject to the Dish with One Spoon Wampum Belt Covenant, which is an agreement to peaceably share and care for the Great Lakes region that we are in. And I encourage others who are online to acknowledge the physicality of where they are and the land that they are on with appropriate gratitude. And so with that, let me just begin by highlighting for Paul that we have here among us, Paul, our first cohort of PhD students for the Global Health PhD program. And I'd like to highlight for you students, you PhD students, that Paul McDonald has just retired a short time ago, a year or so ago, as Dean of the Faculty of Health, where one of his core priorities was supporting the emergence of the Dodela Institute as a research institute here at York. And also supporting the emergence of a school of global health here at York. And then finally, supporting the emergence of a PhD program in global health. There are many people who played a hand in that that sort of triad of activity. But the absolutely necessary institutional leadership that is required to create these kind of programs came from Paul McDonald. And you're here because of his vision and his incredibly dedicated and hard work to make those three things happen. And you'll see, I hope, that through his style and his way of being and presenting, Paul is an amazingly effective and thoroughly decent human being who has achieved many, many, many things in his life, some of which include what I've just highlighted. And Paul now is a professor emeritus, and as I said, a former dean of the Faculty of Health here at York. He's a senior research fellow here at the Dodela Institute. And before he joined York, he was at the university, the Massey University in New Zealand, where he was Pro-Vice Chancellor of the College of Health, also professor and founding director of the School of Public Health and Health Systems at Massey University, and the chair in the Department of Health Studies and Gerontology at University of Waterloo, which is where he was before he went to Massey University. And at Waterloo, he was also the director of the Population Health Research Group. And he's also served as a senior manager in public health on various hospital boards and regional health authorities, and in various roles in not-for-profit settings, and has done so both domestically and internationally. He's been a policy consultant to governments and to not-for-profit entities in North America, Australia, Europe, Asia, over a very long and fruitful career. Has a PhD in health studies with a specialization in population health, a master's degree in clinical psychology, and a BA also in psychology. And his research, which he has maintained over the course of many very significant leadership roles in universities, his research continues to focus on research on broad intervention methods to improve public, population, and global health, primarily through prevention and management of chronic disease, and also the advancement of the idea of well-being, and what is that in an operational kind of conceptual and operational sense. And I could give you many more details, including that he's authored more than 200 major scientific papers over his career. This is a serious man who's done some serious things, and has lived truly a life of purpose. It's very clear, and it really is a great pleasure for me to introduce him and to welcome him to speak with you today. So with that, I'm going to turn it over to you, Paul. I just also want to add one last little thing, Paul. One of the things that I've learned from Paul over my years working with him is he's not fixed in a kind of an anchored, siloed perspective, right? He recognizes the importance of distinctions, right? The importance of creating boundaries, but also the importance of making sure that those boundaries are permeable, right? And that conceptually we don't get trapped in our concepts, right? The concepts are not our reality, right? Our reality is something we attempt to understand through our concepts. And so the idea that he's presenting today, I think, is just a perfect example of Paul's approach, his open-mindedness, his willingness to engage and not be trapped in a particular silo. And so with that, Paul, I'm going to turn it over to you.
Well, thank you very much, James. Something I should tell you about James is that when you speak with him, he's incredibly modest about his own enormous accomplishments, but he exaggerates to all ends when he's talking about other people, myself included. And so just don't believe everything that he said about me.
But something.
I'd like to thank you, James, for the invitation to be here, and of course for your kind introduction. But I also really like to welcome all of our new global health students. It's so exciting to finally see students on campus and helping us to realize the vision of many people, as James said, that took place over the course of several years, really. And of course, a warm welcome to all my other colleagues who have joined us today. I should start by telling you that I'm manifesting a fear of mine. It turns out that I'm under the weather today. I have quite a nasty head cold, and so a great fear of mine is that while I had a cold, someone would want to project my image of my head on a screen so that my head is now 10 times its natural size. This is sort of a latent fear of mine. And so it's being realized today. Apologies if I have to take a break or two for a cough or a sneeze. In fact, the reason I'm not there today is because I elected not to share my virus with you, and I would have probably felt more compelled to talk about infectious disease if I were there in person. All right, so let's launch in. So this is a photograph of a wonderful British statistician, George Box, who in 1976 said something that always caught my attention. He said, all models are wrong, some are useful. And really what I want to do today is make an important point. I want you to consider an example that the frameworks that we use shape our thinking. And I'm going to use an example of non-communicable and communicable disease and ask the question, is a model or a nomenclature in this case, can it hold us back from our own creativity? And I'm going to argue through the course of this talk that in fact has been the case and is continuing to be the case. So I want you to consider whether distinguishing communicable from non-communicable diseases is warranted, and whether you think by looking at things differently, by blending them, as it were, it might open the door to some continual innovation. Now, as I said earlier, words matter. They matter a lot. You know, when I was very early in my career in clinical psychology, I would listen to people come in for assistance, and I was always surprised at the words they use and how they thought of themselves and how they saw and thought about other people. And now in a globalized world, we also see the words people use and how it affects their behaviors with respect to other cultures. And I would submit to you the way that we think about health and disease and how we try to address them is also shaped by the words and the concepts and the frameworks that we adhere to. Now, before I get too far into this, for those who may not be as familiar, non-communicable disease, or NCDs as I'll refer to them, are big. They are a huge global health problem. In fact, almost 3/4 of all deaths worldwide are attributed to NCDs. And 86% of all deaths that occur before age 70 are from NCDs. So it affects not just mortality, but premature mortality in an enormous way. And many people, unfortunately, think about NCDs as primarily something that happens in high-income nations. And in fact, that's not true. That 77% of all NCD deaths occur in low and middle-income countries, and it's a leading cause of death and disability in all global regions. It's also a leading cause of disability, hospitalizations, healthcare costs, and so forth. So this is a significant issue, and so how we think about it is important. Now, there's no formal definition per se of what a non-communicable disease is. But when you go through the literature, including the WHO, who make certain points, they say NCDs are not passed from person to person. They're generally slow to progress and typically in long duration. Well, in fact, as you go through the literature, you see those sorts of things over and over again. You also see people refer to the fact that the pathogens distinguish between communicable and non-communicable disease. So in fact, where communicable diseases are, the pathogens responsible are bacteria, virus, fungi, etc., but it's generally believed that they have no genetic predisposition. On the other hand, NCDs are caused by primarily lifestyle choices, and so you'll see over and over again reference to tobacco use, diet, physical inactivity, substance abuse as being common risk factors. And you'll also see lots of reference to genetic relationships. The most important distinction that you'll see virtually everywhere is that communicable diseases are transmitted not just from person to person, but they can also be vectored through insects, other animals, food, water, and so forth. On the other hand, NCDs, it's very clear in the literature, are not spread from person to person, or so they would have us believe. If you're not familiar with the categories, NCDs would include cardiovascular disease, chronic respiratory diseases, diabetes, stroke, dementia, neurological disorders, certain mental health issues. And examples of communicable diseases, of course, are also well known. Malaria, TB, COVID is an example, HIV, influenza, dengue fever, etc. Now, the use of the term NCD is really interesting. The first time that it seems to have appeared in the literature was 1954. In the 1940s and 50s, we often talked about chronic disease, those things that sort of went on. Ironically, because treatments of so-called chronic diseases were not well developed, people often died, for example, of various types of heart conditions fairly quickly after they had been diagnosed. We now know, of course, that people live for many years with these various conditions. As you see from this particular figure on the right, the use of the term NCDs has just accelerated. It's really proliferated. And you can go back to a paper in 1990, the Global Burden of Disease Study, that really separated pathology into three categories: communicable disease, injuries, and everything else, which they term non-communicable disease. What you saw then, again, was enormous proliferation. The problem with this categorization, as some have pointed out over time, is that, in fact, NCDs has become a bit of a grab bag. It's everything that isn't in one of the other two categories. And sometimes it feels like a bit of an afterthought. And you see that sometimes in important documents. So in the Millennium Development Goals, there's no direct reference to NCDs. Excuse me. But what you do see is that they are certainly part of the new SDGs, including, a reduction by 30% by the year 2030. So that's some progress. But it tells us something about our history. Now, I'm going to argue that in every single case of the criteria that are most frequently used, that the lines are blurred, that it's not easy to distinguish between these two categories. So NCDs, for example, do not always progress slowly. And examples of this are, if you are exposed to some sort of an acute environmental toxin, respiratory problems that can last a lifetime can occur. Chronic brain injuries due to, say, a cerebral thrombosis. Rapid progression dementia. There are cases in the literature of dementia occurring over a period in as little as 3 months. And of course, things like post-traumatic stress disorder, which can become chronic, but occur relatively rapidly. On the other hand, there are some instances of CDs that take much longer than people realize. So the incubation period for hepatitis B is thought to be up to 6 months. Incubation for HIV and syphilis and rabies is thought to be up to 3 months. And then you have the interesting case of varicella zoster, which it turns into shingles, and its reactivation can take decades. So after a person is first exposed to the virus. In terms of the duration and its chronicity, again, not all NCDs now are of long duration, and that's especially true now that we have much more advanced treatments. On the other hand, as we're learning with COVID, there are some types of communicable disease that have long-term effects. HIV, dengue fever, TB are illustrations. If we go on then to the next criteria around etiology, what we see is that the biological pathogens, bacteria, virus, etc. And they can be influenced, we know, by a series of determinants of health. And we also now, and we know from the most recent COVID outbreak, that there is an interaction that occurs between NCDs and CDs. That if you have one, it could increase your likelihood of developing a condition in the other category. In NCDs, for years, I fought this notion of when people start talking about, well, they're due to bad lifestyle choices, as if or lifestyle behaviors. And the fact is that it's an overly simplistic conception that fails to recognize why it is that people engage in various behaviors, and risk factors and the conditions that they live in, that they are typically well beyond an individual control. So we need to ask why people engage in unhealthy behaviors. And when we do, we find out that they're sophisticated and they're quite systemic. And when you think about it, the term pathogen is not necessarily limited to something biological. And so I would argue that there are non-biological pathogens that can negatively impact cells and body systems and organs. And those include things like tobacco and alcohol and certain pharmaceuticals, certain foods, lack of nutrition, environmental toxins, physical and emotional trauma, and so forth. But we also now know that things like chronic poverty and racism and chronic stress can produce pathology. And we're just starting to understand the epigenetic phenomena that's often associated with some of these phenomena. And then finally, I would point out that there are examples of some fairly common NCDs which have a biological pathogen as one of their major risks. H. pylori, for example, is thought to cause about 800,000 cases of gastric cancer around the world, a type of lymphoma, irritable bowel syndrome and cardiovascular disease and so forth are thought to be related to conditions like irritable bowel, dementia, depression, and so forth. And of course, HPV and its relationship to cervical cancer. So once again, what we see is that there is a definite blurring between these categories, and it's not so easy to distinguish them. Now, the biggest and the most common way of distinguishing them, of course, is, are they transmissible? And if they are transmissible, I'm going to argue that it has enormous potential for us better understanding who gets it, under what conditions, and most importantly, what we can do to intervene. Now, when I first became interested in this topic is when I saw this graph from a colleague of mine, Neil Collishaw. Basically, it shows a graph and that if you sort of look at it carefully and study it for a few minutes, you'll notice that different parts of the world had different levels of tobacco use over the course of time. And it was almost as if you sort of work backwards, that tobacco use was being transmitted around the globe and different stages. And then, of course, predictably, if you look at the broken lines underneath, those are what follows in the form of lung cancer. And what caught my attention was the fact that it did seem to just have this pattern of transmission, and that pattern resembles the kind of pattern that we would see with infectious disease. That is what approximates a normal curve. And that the only significant difference here is the length of time that it takes for something to be transmitted and for its pathological effects to take place. It's interesting to me that there's a a huge literature that's developing right now around social networks and impact on health. And one of the most prominent areas is the notion of social marginalization, those people who are not integrated within any kind of a social network. And we now know that, interestingly enough, it increases the risk of various NCDs, including ischemic heart disease and dementia and depression, to name just three that have been studied to date. But we now know that non-biological pathogens also spread through social networks. And let me refer you to the work of Christakis and Fowler in 2008. And I should tell you that their work is not accepted by everyone. There are those that are quite resistant to their notions. But I think that as other people develop and use different methodologies, that we're going to find out that, in fact, they were on the mark. What they did was they looked at over 12,000 people over a period of 32 years in the Framingham study in the eastern US. And the bottom line is that what they found was that obesity and tobacco use appeared to spread through social systems. And I'll get to this notion in a moment, but what they also found in subsequent work was the protective effects of health and well-being, like happiness, and the interventions that we use to help people quit smoking, for example, or overcome obesity, also can spread through social networks. And that is incredibly important. What they showed was that if you had a set of friends, if you named, say, 10 friends, and if those friends smoked or were obese, you were yourself more likely to smoke or become obese. Now, that's not particularly earth-shattering, but what was earth-shattering is that they looked at the network, and so then they began to ask the friends of all a person's friends. And again, they found an association between various behaviors and the likelihood that a person will say, since it was Nick Christakis that looked at this, will say, Nick, if his likelihood of smoking, say, went up as his friends smoked, and the more friends that smoked, the greater his risk. But the friends of Nick's friends also showed a relationship. And where it was really wild was the friends of Nick's friends' friends also showed a relationship and impact on Nick and his likelihood of smoking. Now think about this. Think about 10 friends that you have, and then ask each of those 10 friends to name 10 people that they know, and then those people to name 10 people. How likely is it that the person of origin knows those third order connections? And the answer is not likely at all. What that means is that people who are perfect strangers to us, without realizing it, have an impact on what we do, and the vectors, as I'll explain in a few moments, of NCDs. So again, they turned it around, and I'll call your attention to the right-hand side of this graph. First, this is just a random sample of 1,000 subjects in the study, and they looked at them in 1971 and again in 2000. And what was really interesting, if you look really closely, first of all, you'll see a lot less yellow dots. The yellow dots represent somebody who is a smoker. But when you look at them in 1971, they're all along all branches of the network. But in 2000, the vast majority of the smokers are at the edge of the networks. They've been pushed out and marginalized. Now, you might say, well, okay, this is you know, an effect we've seen before. You know, a spouse smokes, you're more likely to quit smoking by 2/3. If you know, you have a sibling who quits, you're likely to quit, you know, an increase of 25%. If a friend of yours quits, you know, you're 36% more likely to be successful. But it goes on and on, up to 6% of an impact by third generations or third order connections. What's crazy is that geographic proximity does not play a role. That whether your neighbor quits or not is dependent on whether or not you know them and not the fact that they happen to live next door to you. So it's not a proximity effect. It's a social network effect. Now, if you're a skeptic of Christakis and Fowler, that's fair game. But here's some other work that's been done. This is a fellow by the name of Barr, and he found that dieting with friends doesn't really help people lose weight. But when people dieted with the friends of friends, it was effective because it shifted the network boundaries. It safely ensconces the dieter in a cluster of low BMI people in this particular case, which is in effect what's called a social network effect. Interventions targeting key influencers and or normal weight individuals at the edges of those clusters had an enormous impact in reducing the spread of obesity within those networks. Why is it important? It's important because it suggests to me that NCDs are communicable. If we think about pathogens, if we think about vectors and we think about sort of pathology, if we look at NCDs, the transmissible vectors are both biological and non-biological. They include genetics, epigenetics, individual people, our family members, our communities, the social networks to which we belong, social media, cultural practices, poverty, inequality, homelessness, conflict, politics, developmental practices, commercial practices in business, and so forth. Those are all things that propagate unhealthy eating behaviors, tobacco use, and their negative effects. So I would argue that we are missing a huge opportunity by defining a whole bunch of diseases as non-communicable. We limit ourselves in the way that we think about and respond to these conditions. Now, I'll just share something I'm thinking about more recently. And it is that the health of a population, then, if you come to this conclusion, the health of a population is not a simple aggregate. It's not a sum or an average of the health or the risk status of all the individuals within that population. I would argue that it is a product, and it is a product of all the individuals and all their various interactions between individuals and contexts within that population and across populations. What we have to then consider is the various ways that people, communities, nations are connected or disconnected, as the case may be, through social context, economic context, political context, cultural context, and so forth. It gets complicated. But let me offer a way to sort of think about this that in some ways helps simplify all of it. We can think again about pathogens, whether they're communicable, non-communicable, whether it's injuries, and we can think about the vectors for how they get transmitted to people and communities. And interestingly enough, if you want, you can actually talk about health and well-being as well. And so instead of a pathogen, you can speak about cellulogenesis. That is, the things that make us happy and well. And they too, I would argue, have a set of vectors. And the more creative we are in identifying those vectors and how those vectors interact with each other, the more power we have to intervene in various times, places, and so forth. Now, I realize that you're going to have an upcoming lecture on this, so I'm just going to introduce it. And this is where I come from. I think of the world as a gigantic system, and it's a science for seeing wholes, whole objects, for seeing interrelationships between things and people and elements. and seeing patterns rather than static snapshots, as Senge has identified. It provides a set of general principles, a set of tools and techniques. It's a system of a whole, of a set of dynamic elements that are constantly shifting and changing and so forth. And in our case, it helps us to understand complex relationships between broad pathogens, their vectors, and their disease outcomes. This is a very simple diagram that was produced in 2007 using some of the approaches of systems thinking. And, we used to ask, well, why do people become obese? Well, we would give a simplistic answer. They don't eat right and they don't exercise. Well, it's far, far more complicated than that, as this diagram shows. There are a whole series of variables that one has to take into account in order to fully understand what's going on. So I'm going to wrap up here by saying I've argued that we need to consider and adapt our methods from infectious disease to advanced so-called NCDs. The models used in infectious disease are quite interesting, and they could really help us deal with those that we have traditionally called non-communicable. They could advance our understanding of how they occur, where they occur, when they occur, and most importantly, how to intervene to ameliorate their effects. It could facilitate new supportive social connections, disrupt pathological connections. So, for example, social media is another area that we're just beginning to understand its pathological consequences. Taking more holistic perspectives, thinking about planetary health, humanitarianism. It's not an accident that the Dodley Institute has chosen these as particular areas of interest. They're all interconnected. We can identify and act upon new determinants of health. Thinking about commercial determinants of health and digital determinants of health give us new opportunities to intervene in new places with new systems and new people. We can think beyond acute care, primary care, and long-term care, and as that being the foundation of preventing and intervening with those things that have traditionally been called non-communicable. So NCDs, CDs have overlapping characteristics. The models and nomenclatures that we use, I believe, have done us a disservice in the way that we're thinking about these critical issues. And while splitting the world into categories can help us understand fine detail and are useful, I'm not saying they're not, but I'm saying that we need to balance that with a more unifying approach, which facilitates learning and generate efficiencies across diseases, across specializations, literature, geographic regions, and so forth. And so for those of you who are starting out in your journey, and for those of you who are well into it, I want to challenge you to not be afraid to question the status quo. And doing so is what will enable us to continually move forward as a science in areas of policy and, of course, practice. So I have a few questions and so forth. We come back to that if you wish, but for the moment, I'll stop there because I don't know about you, but I've had about as much of myself as I can take, and I'll turn it over to you. And I'd love to hear your thoughts, not just your questions, your ideas. Do you agree with this? Do you have some concerns about the approach? What does it mean? The floor is yours.
Go ahead, Michael.
Right. Thank you very much. I'll make this very quick. There is a time issue with your argument. You didn't quite deal with what the changes that happen over time. And that's the first point. The second point is perhaps you might offer some ideas on how this sort of dynamic notion that health is non-biological, but there are other factors to it. How you might, even within academia, harmonize the different determinants that are non-biological, for example, in an academic study.
Before you answer, Paul, I'm going to just ask for one other question, and we're going to try to group because there's a lot of questions. Go ahead.
Yeah, thank you so much for your presentation. I was actually wondering, would you be able to share your slides with us as well? Just because there was a lot of really great information in there. And then my other question was about this sort of balance between having these models for efficiency, for heuristical thinking, mental shortcuts, and then also addressing the appropriate complexity that sort of reality offers.
And go ahead. And last one, Paul, go ahead.
Okay, just a quick comment, because my mom is a cancer doctor in the Philippines, and then my mom's a cancer doctor in the Philippines, and I definitely agree with those short-term diseases, because a 12-year-old was able to develop cervical cancer after being, I think the term is raped by her father and uncles at the same time. So her body wasn't able to adapt right away to the situation. So aside from other HPV she also developed cancer right away. So yeah, I definitely agree with your lecture today.
Thank you. Over to you, Paul.
Well, I don't have all the answers, I'm sorry to tell you. The purpose of this lecture was hopefully to stir your imaginations and thoughts. Being critical of each other is one of the greatest services that we can provide, but doing so in, of course, a respectful way. Let me start with the easy one, which is going to share the slides. As far as I'm concerned, yes, absolutely. James, I'm assuming that there's a way to do that through Dadla.
Yeah.
In terms of how do we sort of think about all the various non-biological factors? Well, they're all kinds of vectors. We tend to think that we can only catch a virus or a disease, but as we're seeing in things like suicide, for example, somebody coming across another suicide, or somebody generating ideas, or the kind of bullying behavior that we see online can push individuals to attempt or to actually commit suicide. It's just a vector, and so we need to be thinking about, well, what are the realm of possibilities of all the vectors? Now, all the vectors aren't going to be equally powerful with all people all at the same time. But what we're learning, for example, over the last few years, I've seen a proliferation of us thinking about what are called commercial determinants of health, and how business and the way that they operate and so forth can sometimes wittingly and sometimes unwittingly proliferate things that put people at risk for all kinds of negative health outcomes, both communicable and non-communicable. So whether that's a listeria outbreak, or whether it's a car crash because of poor design, or whether it's putting an additive in foods that increases the risk of cancer, etc. So that's an example. And I've also recently heard people talk about digital determinants. They're all a kind of vector. And if you sort of think about them in that way, it does open the door for us to think differently about where we intervene and how and with whom. And then the issue of time, I think, was brought up. I think my point was that, all infections don't occur quickly, and all NCDs don't necessarily unfold over the course of time. And as we think about NCDs in particular, there's quite a bit of interesting work showing that the seeds of certain kinds of conditions are often start very early in an individual's life. We're just not very good at detecting them and assessing them at the end of the day. And so I think there's a lot more work there that needs to be done. And so, when does heart disease start? Does it start when you have sort of an ischemic attack? Does it start when you're fortunate enough to have a stress test and it gets picked up? Or does it happen in childhood when you start to pick up maybe some atherosclerosis that is abnormal? Who's to say? But thank you. Those are all good questions.
Great questions. Godfred.
Yeah, so thank you so much, Paul. It's good to hear from you. I think you make a very rich presentation on this, at least from my perspective, from a systems angle, in seeing that making distinctions and also looking at the relationships between these two categories have a way of presenting to us unique characteristics in each case, whether non-communicable or communicable. However, I believe that looking at them holistically together helps us have a better way of understanding the etiology and sometimes how we can go about preventing these diseases or treating them. And so certainly it is key. It is a very good thing. As you were speaking, I started thinking a bit more carefully about some distinctions I would have to make on Sunday on planetary health and One Health and what that means for how we are approaching the challenges facing our world today. So it is very important. And that also reminded me of some cultural values that we probably do not bring to light when we are looking at non-communicable diseases in some parts, at least some parts of Ghana, where the perception of who is wealthy, the perception of social class has more to do with sometime, unfortunately, whether you're obese or not. Right, because then that is the notion that you have access to some kinds of foods that others do not have access to, right? So over time, we do see that it is in some sense communicable, even though we would consider obesity and the risk factors associated with it as non-communicable. And there's a label that this is the rich man's disease, right? So from a cultural anthropology perspective, you can see exactly what you're talking about. But I also wanted to chime in the last comment you made about particularly when you think specifically about obesity, I've also seen research that suggests that seeds of obesity can be planted much earlier when children are below the ages of 5 years, depending on what you expose them to. You begin to create certain adaptations within their cells, which then, by the time they are 20, 25, 30 years, then creates that platform for them to be obese. So I think it's interesting we think about these distinctions, relationships, but most especially think about them in a more holistically fashion.
Yeah, let's let Paul. Would you want to comment on that, Paul?
No, just to add a couple of things, and thank you, Godfrey. It's nice to see you. A number of years ago, I had the privilege of visiting Cape Town, South Africa, and I heard Desmond Tutu speak. And he described an African philosophy called Ubuntu. And so I had the chance to ask him about it. And he gave me the most eloquent response. He said, "It means I am who I am because of who we all are." It is the notion that we're all sort of inextricably linked with one another. And I think that that's the piece that we forget. We certainly forgot that during the COVID pandemic. And that people saying, well, I'll look after myself and I don't want people interfering, et cetera, et cetera. People get what they deserve, all that. Well, if you look at it from the lens of Ubuntu, what you begin to realize is that I, as a person, cannot reach my full potential unless those around me do as well. And they cannot reach their potential unless I do as well. We are interconnected. And I think that, to me, that was a beautiful sentiment, and it greatly influenced my thinking. And again, why it is that sometimes we just get caught up in this nomenclature, and it's not all that helpful.
Thank you, Paul. Go ahead, Imran.
Thank you
And
so
just
much, Paul.
briefly, and then, yeah.
Thank you so much, Paul, for freeing our minds of these categories and allowing us to think more broadly about these questions and what to do in response to these diseases. One parallel that I saw emerging, especially in that unifying approach slide, when we talk about communicable so-called diseases versus non-communicable diseases, is that there are two kind of categories of how we respond to them. There are individualized approaches, and then there are the collective approaches, right? So in the context of a communicable disease, like I work a lot on water-related disease, so like cholera. Everyone's trying to find the silver bullet for cholera. We have a vaccine now, and there's so much emphasis going on expanding vaccine production and delivery, et cetera, without doing it with the underlying environmental causes that drive cholera, right? And there's this tendency always to look for that silver bullet individual solution at the expense of the collective solution. So I see that in this applying this thing to NCDs as well, we really expose how all of our approaches have been behavioral, individual focused, whereas it's really the environment that's shaping people's propensity here. So it's driving our attention again to the social collective solution. So my question for you is, do you hope that this conceptualization is a counterweight to like the individualized biomedical approach to NCDs? How do you see this playing out? What do you hope to spark amongst health thinkers with this framing?
Yeah, I just like to point out that I don't think there is a right way and there is a wrong way. I think there are multiple ways of thinking about things and approaching things. I'm just trying to, my purpose today was just to encourage everyone sometimes to take off the blinders. When I was a PhD student, we were told to think in a certain way, and this was the prevailing thought at the time. And over the course of my career, as new evidence emerges, I begin to realize that some of those notions, of course, were not particularly helpful. And so, one of the messages I wanted to leave is it's okay to question. It's okay to ask hard questions. And in my case, I'm hoping that I'll add value by getting people to, that I'll add my voice to a chorus of people who say, I think we have to look more systemically. I'm certainly not the only one. There's a large and growing number of individuals. Many people may not realize this, that one of the early thinkers in systems thinking, particularly as it relates to healthcare, was a professor in the Schulich School of Business at York University. And she passed away a few years ago, Brenda Zimmerman. But Brenda was brilliant, and among the people leading the charge and helping people to understand the world is a complex place, and we can either deny it or we can accept it and figure out how to work with that complexity. And so I'm hoping that some of what I can do is to add value to that, and that in some ways by reducing and using terms that are familiar to people like vector, like pathogen, et cetera, and sort of reconceptualizing them a bit, I'm hoping that brings a little less complexity to something that otherwise seems a little overwhelming at times.
So, Paul, I just want to make a couple of quick comments. And I have to say that as I listened to your presentation, I kept thinking of Louis Pasteur. And as most of us will know, Pasteur was the founder, if you will, of microbiology. He identified the first organism under a microscope and came up with, that was the beginning of evidence, concrete evidence of germ theory. And now Pasteur, when he looked through that little microscope, what did he see? He saw black and white and light. He didn't see in the first instance microbes and little particulate matter on which they live. But what he saw was black and white and light and different diffractions and so on and so on. And his models or his ways of understanding, which were not yet formulated, right, led him to identify or to see that in that pastiche of light and dark that he was seeing through the microscope, it led him to formulate this idea of a germ. And from there, human beings have moved very quickly through that concept to very, very powerful applications and very powerful interventions in public health and medicine and so on and so on. But one of the things, so I just want to really reinforce where you started, Paul. This idea that models they're not like the 11th commandment. They don't just sort of exist, right? We create them, right? And we create them through our conceptualization, and that we shouldn't be trapped in our concepts, but we should use those concepts, but not be trapped by them. The other thing that Pasteur said, and this is little known, but very important. He said, and I quote, "The microbe, which he discovered, the microbe is nothing. Its milieu is everything." So that's a very powerful understanding, or at least explication or use of words to try to express the complexity of what he was experiencing and then trying to communicate through words as forms and forms as concepts to help us kind of understand a phenomenon. So I really just loved your presentation, Paul. I just thought it was fantastic. You just challenged us on every front. The last thought I want to share is when I think about some of the current, and you referred to this, Paul, systems thinking. When I think about systems dynamics theory, and I also think about the emergence of artificial intelligence as a tool, there are many, many very powerful implications of the marriage of those two tools. One is a conceptual tool, another is also a conceptual tool. When you bring them together, they are incredibly powerful. Now, what does AI do? More than anything, what it does, what it can do, is identify clusters of data points, right? And it can very rapidly identify this cluster with that cluster with that cluster and find correlation. And when Paul's talking about causality, another term that we have traditionally used really since like the mid-18th century is correlation, right? The strength of a correlation between clusters and then also between systems of clusters, right? This is how we understand, at least mathematically and scientifically, how we understand the idea of causality. And so if we take that and apply it to what you've said, Paul, around NCDs and CDs, communicable diseases, and even injuries as that third category, The question is, what are the relationships, right, between clusters of events, and I don't necessarily mean outcomes. I mean events, phenomena. What are the relationships across time, and is that slow time, or is it fast time? Right. So, are we thinking about a lifespan? Or are we thinking about a 24-hour period when we look at, for example, a meningococcal infection, right? So I just want to thank you, Paul, for just inviting us to expand our minds and to open up to new ideas, new ways of understanding, and to be unafraid to question what has been previously assumed. For me, that's the mark of of somebody who spent a lifetime really thinking about these things. So Paul, thank you so much. That was absolutely fantastic.
Well, thank you. I appreciate the invitation. And to those that I haven't met, when I'm on campus, I am on campus infrequently. I live actually about 300 kilometers from campus, but I am on campus from time to time. And if you see me, will you please introduce yourself? I would really like a chance to chat with you and get to know you.
Yeah, and it's very much worth your effort. And Paul will be here at the Institute. He knows that he's always welcome. He's a senior scholar here, professor emeritus at the university, but he's a senior scholar at the Institute. And he has space here and so on. So if and when you see him, please do reach out and say, hey, let's have a cup of tea, a cup of coffee. Let's just chat. And with that, Paul, thank you again.
My pleasure.
All right. And